Assalamu alaikum jami'an. Good evening, everyone. So I thought today to present evidence-based medicine. Although all of us, since long time, we are practicing evidence-based medicine routinely in the clinical care of our patients. But I thought to revisit this topic because to see where we are standing, do we need to stress on critical parts of the evidence-based medicine practice. And I think this topic, as well as the biostatistics, among the most important topics to be discussed every now and then, or to revisit it every now and then. So I will start with a small history or brief history about the evidence-based medicine. What is it? What's the magnitude of it? Then what was the situation before, then after the EBM? How we can practice EBM? What are the rules? What are the concepts of it? Then what are the limitations of it, and how people are think about EBM? I mean the negative feedback from people about the EBM. So I will tell you a story that can tell you about the situation before the era of EBM, which is the flecainide story. Flecainide, as you all know, used to treat heart attacks in US in 1980s. This example is a dramatic one that shows the gap between research and clinical practice and the reliance on evidence of mechanism rather than an outcome. In 1979, Bernard Lown pointed out that one of the biggest causes of death was heart attack, mostly in young and middle-aged men. People had heart attack, developed arrhythmia, and died from arrhythmia. He suggested a safe and long-acting antiarrhythmic drug that protects against ventricular fibrillation, which is flecainide. In response, a paper was published in a peer-reviewed journal, New England Journal of Medicine, introducing flecainide as antiarrhythmic medication. So they took 9 patients because this was an initiation of an evidence, only 9 patients with preventricular contractions, and they used for them flecainide. They found that there is a significant reduction of preventricular contractions in those patients who use flecainide versus the placebo. So the conclusion was straightforward. Flecainide reduces arrhythmias, and arrhythmias cause heart attacks. This is the mechanism. Therefore, people who have had heart attacks should be given flecainide. After this trial, other researchers have started gathering information on the survival of patients with preventricular contractions, which is the outcome, instead of the mechanism itself, which is the reduction of rate of preventricular contractions. They found a low percentage rate of survival in flecainide group versus the control group. Unfortunately, because of evidence lag, about 9 years between the first and the follow-up study, about 200,000 people were being treated with flecainide in the US by 1989. As a result, tens of thousands of additional heart attack deaths were secondary to flecainide. This story tells us 2 lessons. Up-to-date, good quality research finding must be available to all medical practitioners on a routine basis. Second thing, that empirical evidence of effectiveness using a clinically relevant outcome like survival, improved quality of life, is more important than research based on mechanistic approach only. And this is why we see now the evidence is focusing more on those outcome findings. So about the history of evidence-based medicine, in late 1970s, Prof. David Sackett started to think about the importance of integrating the evidence into the clinical practice. At the beginning of 1981, he published a series of articles called The Reader's Guide to Medical Literature. In those series of articles, he focused mainly on the importance of evidence-based medicine, the rules of evidence-based medicine, but he did not stress enough on the critical appraisal. So afterward, after his death, his colleagues started to think to upgrade this guidance. And in early 1990s, this guidance, they tried to focus more on the appraisal of critical evidence and trying to link it with practice. So they changed the name to the User's Guide to Medical Literature. They suggested to name it Scientific Medicine, but many of their colleagues opposed this because they thought it means that what we practiced before was non-science. So later on, they changed the name, late 1990s, to evidence-based medicine and started implementing this in McMaster University, and afterwards started to spread to the rest of the world. So what's evidence-based medicine? It's integrating the best available evidence in the medical literature into the daily medical practice. This is the simple terminology or statement of definition. EBM is a new paradigm of clinical practice and the process of lifelong learning. And this is very important. It's not only a task that should be done once, it's a lifelong learning process, which emphasizes a systematic and rigorous assessment of evidence for use in decision-making in healthcare in conjunction with expertise of the decision makers, and this is very, very important, and expectation and values of the patients. So 3 components in evidence-based medicine. The magnitude of it, the benefits of evidence-based medicine, it's not only to solve issues or cases during our practice, which is the first thing, the problem-solving strategy, it's empowering strategies. It means that it will give our clinical decision a strong support. When you ever gonna take a clinical decision on your patients, you have the backup from the evidence. Waste-limiting strategies, we are avoiding unnecessary practices by using the evidence-based medicine, which will improve everything and reduce the waste. Quality improvement, of course, protective strategy against misleading information, because now we are bombarded with a lot of information, but using EBM will reduce this. Communication facilitating strategy, especially we are using the multidisciplinary approach in our hospital. Learning, of course, learning strategies for the trainees, including fellows, residents, interns, etc. Information handling strategy, collaborative work, because many experts from different fields are discussing one evidence with their different experience. And of course, in an academic hospital, it's a research promotion strategy. So a lot of benefits from evidence-based medicine. The era before EBM, although I mentioned the story of flecainide, but we have many, many stories about how people were away from evidence and how was the practice before that. Before the dawn of PM, the provision of healthcare depended on following sources for guidance and information. First, the physiologic rationale. They rationalized things by physiology. One example, in ischemic stroke, they thought, since there is a clot, let's use streptokinase in order to dissolve this clot. This is physiology and something logically. They started using streptokinase, but eventually with time, they found in the study there is a very high mortality rates. So the negative outcomes were outweighing the benefits. But when they used TPA, which is the same as streptokinase, they found that the mortality risk is much lower with some benefits. So sometimes physiology will not explain everything for you. The evidence may oppose the physiology. Experts' advice is very, very important, but sometimes in the era before EBM, they rely only on their experience. Textbooks and reviewers, and we know that textbooks and reviewers are sometimes outdated, not updated very frequently. Manufacturers' claims, and this is among the misleading information, and whenever you have a study supported by manufacturers, you need to carefully address or appraise the article or the literature. So when we compare before and after EBM, in regard to the clinical and medical education, they thought that only the clinical and medical education is sufficient to practice EBM. But it's not, as I mentioned, a task or a curriculum that you will take it once and then you can practice it. It's a lifelong learning and self-directed. You have to work on yourself. Clinical experience, they found also, or they were thinking before EBM, it's sufficient to guide practice. And this was the most important concept before the EBM. But you need to be aware of research results along with your experience. Textbooks and review, which are the traditional articles, they thought as well they are sufficient, but they are useful, but not, of course, sufficient. Evidence from basic and animal research, before they relied on basic research and not including clinical trials, but now we have to rely on clinical trials, although we can take some ideas and hypotheses from animal studies and apply it in human. Validity of publications. Before EBM, they thought that all that is published in top journal is largely true, unless contradicted by another publication. And unfortunately, some people are still believing that if there is an article published in New England Journal of Medicine or any other journal, this means whatever the results of this trial, we don't have to critique it, we have to take it and apply it on our patient. But most of what is published, even in top journals, can be still questionable. Reading conclusions of paper, and this is also the same. I think many people are having this attitude that I will read only the conclusion and I will start applying it if it's positive or avoiding it if it's negative. You have to critically appraise the article. You have to consider the methodology, results, as well as discussion. You have to read the whole article carefully before deciding anything. Critical appraisal ability, they thought that it comes automatically and informally with medical education and experience. But as I mentioned before, it needs to be learned actively and formally. This is like what we did with the journal club. And even though some centers, they think that they are pioneer or they are good enough in appraising the article or doing journal clubs, but even with time, you have to improve your skills in doing journal clubs. Statistical significance, we have to differentiate between something that is statistical significant, which is not enough, and something that is statistical as well as clinically significant. I will tell you another story about, which was in 1956, about the infants when they sleep, either to use the front or the back position. So Dr. Benjamin Spock published this book, Baby and Child Care. He addresses many aspects in the child care, among them the positioning of the baby while sleeping. So he favored front positioning to eligibly reduce the risk of choking with vomitus, avoid head flattening, reduce wind, and improve respiration. This book has actually sold more than 50 million copies at that time. Until his death, his book was still released in the market and still they ran out of copies. They mentioned that it's only outmatched in sales the Bible. So in 2005, imagine how many years after this book, a meta-analysis was published to investigate the effects of infant sleep position on sudden infant death syndrome. And of course, they found this position, the prone position, was worse. So this is why we should always appraise, not only appraise the evidence, update the evidence that we have, because sometimes initially the evidence will show good results. With time, when you do more results on more population, you will have the opposite results or negative results. So regarding the rules of EBM, knowledge about EBM follows the 1, 2, 3, 4 rule. 1 is the goal of EBM, 2 are the fundamental principles, 3 components, and 4 are the steps. So the goal of EBM, of course, is to improve health of people through decisions that will maximize their health-related quality of life and lifespan, which are the most important things, survival and quality of life. And this is why most of the studies are stressing on those outcomes. The decision may be in relation to public health, healthcare, nursing care, or health policy. Regarding the principles of EBM, 2 principles. First, the hierarchy of evidence, and I think all of us are familiar with the hierarchy of evidence. So evidence available in clinical decision-making can be arranged in order of strength based on the likelihood of freedom. So in the top of this hierarchy, we will find systematic reviews and meta-analysis of RCTs. The second level, multiple RCTs. Second, single RCT, cohort studies, case control studies, then cross-sectional surveys, cross-sectional studies and surveys, after which case report and case studies, then at the end, the expert opinion. So the higher you are going on the hierarchy, the higher quality of evidence, the less the risk of bias. Going down, more risk of bias, and more you have to be careful in appraising the evidence. Because already you know it's weak, so you have to be careful when drawing any conclusion from a weak evidence. The second principle of EBM is the insufficiency of evidence alone. Which is that evidence alone is never sufficient for decision-making. It has to be integrated with clinical expertise and patient expectation and values. Even at the beginning of era of EBM, people thought that I will use my experience, plus I will read the evidence, but they don't include the patient expectations and values in their decision, which is very important. And I will talk about it in the next slides. The three, we finished from the goal, the principles. Now the components of EBM consist of three components: evidence, expertise of decision makers, and the expectation and values of patients. In regard to the evidence, as I mentioned, the hierarchy of evidence. Regarding the expertise of decision makers, one sample example, and we have in mind a lot of examples that show us that experience alone is not enough. So a 16-year-old male is admitted to the ICU with ascending paralysis and respiratory distress. The resident makes a diagnosis of GBS and start to discuss evidence-based approaches to manage GBS. So the consultant comes, he took a history and dig deep in the history and suspect that the patient have dump rabies because of the history. He was having dog bite like 3 months ago, and he took the primary immunization partially. So the further investigation confirmed the suspicion of dump rabies. So by the end, the discussion was made about the GBS was invalid because yes, it's evidence-based medicine, but from the beginning, the diagnosis was wrong. The second, the third thing is the expectation and values of patients and people. One example, there is a consistent evidence to show that alcohol in moderation is protective against heart attacks and stroke. However, of course, in Islam, alcohol is forbidden. It would be unacceptable to discuss alcohol intake in moderation with a Muslim, even if he has many risk factors for heart attack and stroke. Another example, of course, about the expectation and values of the patient. Some of the patients still, and I think most of the doctors handling patients who needs biological agents are facing this. Many patients are refusing to take biological agents for, they have many concepts about it. They thought that immunosuppressants will suppress the immune system rather than make it work. So we have to work with these patients' expectations and values and try to find the best solutions for those patients. To emphasize all the three components, the word triple E-based medicine has been used in some references. So we can say triple E-based medicine, which is evidence, expertise, and experience-based medicine. To meet the goal of EBM, 4 key steps are necessary. First, ask for the required information by formulating your questions. And this is very, very important because sometimes when you are looking about specific management for your patient, you will search the literature without having a specific question in your mind. This will waste your time without finding the proper answer that you are searching for. I will talk about it in the next slide. Acquire the information by searching the resources, assess or appraise the relevance, quality, and importance of the information, then apply the information in your patient. Those are 4 steps or 4 A's. Another approach is to use 6 A's, which is the same to formulate a question, which is asking, then acquiring, searching for the proper evidence, appraising, Then aggregating this evidence, weighing and pulling together the evidence, because you will have a bunch of evidence. You have to take among them the best evidence, then applying it. After that, you have to assess the outcomes after applying this evidence. So starting with asking the required information by formulating your question, usually we are using the PICO format. P for population, I for intervention, C for comparison, O for outcome. Sometimes we don't have a comparison, only population, intervention, and outcome, so PIO. Always put this in your mind when you are asking any clinical question. Second thing, you have, of course, to search the literature to find the best available evidence, as I mentioned before, regarding the hierarchy of evidence. The third step is to assess or appraise the relevance, quality, and importance of the information. And this is very important. There are 4 issues in critical appraisal. First, is it relevant? The extent to which the research paper matches your information need based on the PICO criteria. This is why, again, you have to put a specific question in your mind in order to find something relevant to your question. For example, someone may ask, I want to use heparin for a patient with acute stroke. If you put this and try to find an answer for it, you will find a lot of articles. And sometimes the population is not relevant to your population, or the outcome is not relevant to the outcomes you are looking for. So you have to be more specific. So instead of using what's the role of heparin in acute stroke, you will use, for example, your patient already on aspirin, you want to add to him heparin. So you will ask this question: aspirin plus heparin in elderly, if your population is elderly, with acute ischemic stroke, and we have many reasons for acute ischemic stroke, you will write due to atherothrombosis on, you have to specify the outcome. Sometimes you are looking for reducing, for example, hematological complications. Sometimes you are focusing on reduction of the rate of survival, and etc. So you have to define your outcome. The outcome here was full recovery or independence in activities of daily living. Having more specific questions will help you to gain or to retrieve the relevant literature. And this is very, very important, as I mentioned. Validity, it means the extent to which the results are free from bias, especially selection bias, measurement, and analysis bias. So you have, when you appraise the article, to see regarding the selection of population, was it representative? Was it randomized? And you have to address all these points. Measurement bias means, did the person who measured those outcomes blind to the intervention or not? Also, you have to see if they specify the criteria of outcomes or not in order to measure them properly, because sometimes some criteria are measured subjectively rather than objectively. Having objective outcomes better than having subjective outcomes, if available, of course. Analysis bias, did they use intention to treat analysis? Did they measure all the patient, even those who has lost a follow-up? And was the person who did the analysis blinded to this or not? Internal validity, we have something called internal validity and something called external. Internal means, are the results correct for the subject in the study? We are always addressing this question in the journal club. So we have to appraise the results part. External validity, this is the question where we ask, are those results from this study applicable to my population or not? Sometimes the evidence is wonderful, the outcomes are very, you will be enthusiastic about them, but unfortunately you cannot apply it to your population. And this is what's called external validity. Regarding the consistency, it's the extent to which the research results are similar across different analyses in the study. I will give you an example to make it clear for you. We have something called internal, we have something called external. Internal consistency means sometimes we are taking a population, then we will do our analysis. We will find that, let's say, therapy X improved the survival in those patients. Then when I did for those patients a subgroup analysis, I found only one of the group benefit, while the rest of the groups did not, or it was not statistically significant among them. Having this difference, it means your result is not internally consistent. If the whole group versus subgroup achieve the similar results, it means that your study is internally consistent. Sometimes, طبعاً, not all the studies will achieve what you want. They have internally, externally valid, internally and externally consistent, but at least the evidence you have with all of these, it means the best evidence to go with. External consistency refers to the consistency of the study's findings with other studies. For example, you conducted a study and you found results completely different from like 7 or 8 studies done before. And you use the same methodology, let's say both or all were RCTs, including your own. Having a different result from previously published 7 trials, it means that there is either something wrong with your trial, or you have to go back to see if you have something superior in your methodology in reference to those previous studies. So you cannot rely only on your study, which have positive outcome, while the other studies have negative outcomes. So external consistency is very important. And lastly, the importance or significance of result. Sometimes you will find results are statistically significant, while in reality, it's not clinically significant. So this is what we can see in survival days in oncology studies. The pipeline of oncology studies is huge. They have many studies. Every day you will find a new published studies regarding new therapy for any oncology disease. You will find they focused on mortality and survival days. If, for example, the survival days improved by like 5 or 10 days, you may find this statistically significant, but for the patients, 5 days means nothing in survival. So this is clinically irrelevant for oncologists. They will see this is clinically irrelevant, so we will not rely on the findings of this study. Assessing the or appraise the quality, and you can use some checklists to help you with the appraising the evidence, especially if you are doing journal clubs. You will find, if you even Google it, you will find like the systematic review checklist, case control study checklist, randomized control trial, because you cannot use the same criteria or parameters to assess different types of studies. Because you know that what applies in RCT cannot be applied, of course, in case control study because the level of evidence is completely different. There are some sites you can register and you will find a lot of things that can help you with the critical appraisal. Applying information in your practice or patient, finding the information in a paper that is relevant, valid, consistent, and important. The next step is shaping the recommendation to fit your patients. And this is very important. And this is why we call it individualized therapy. Sometimes we have like 10 patients having the same disease, but the intervention I'm going to apply is only applied on one of these patients, not all of them. This is called tailoring the therapy on our patients. This is where clinical expertise and experience becomes handy. When you are tailoring the outcomes of the research on your patient, you need to have an experience. Common things we are facing routinely, which is the debate on IVIG use when diagnosis is still vague. Sometimes you will find a good evidence to support, but still you don't have a definite diagnosis. So to go or not to go with the IVIG, it needs your experience in order to find the risk versus benefit in your specific patient. In summary, this is the 1, 2, 3, 4 rule of EBM, the goal, the principles, the 3 components, and the 4 steps. I will tell you some about the misconceptions about EBM. Some people are not frequently practicing EBM. They will take their medical education, then after that they became consultant or something. They will not learn frequently. They will not use the evidence. They will rely only on their experience. So the misconceptions are that evidence-based medicine ignores the practitioner's professional experience, and this is totally wrong, because you have to have a good experience in order to take the evidence and apply it in your patient. It's all about numbers and statistics. Those numbers and statistics are made in order to quantify the results and then convert it to clinical outcomes. Managers need to make decisions quickly and do not have time for evidence-based practice. Of course, this is not true. You have to take your time in order to assess and appraise the evidence. And with time, with experience, with learning, you will start reading things faster, assessing and appraise the evidence more faster, and come up with a conclusion that fits your patient. Each organization is unique, so the usefulness of evidence from the scientific literature is limited. And this is, of course, wrong. We know that the studies are not conducted sometimes in our countries, in another country, in a different ethnic population. But despite that, still it's a sample representative of the population. We can address all of these things in the critical appraisal and try to apply it, because we cannot conduct a study in the whole population or in the whole people in the world. If you do not have high quality evidence, you cannot do anything, of course not. And this is, we can see it in pediatric. Usually we will face with situations where we have a very weak evidence, but despite that, we have to use it. How to use it properly? This is where the experience and the how good you are in evidence-based medicine will come to help you. Good quality evidence gives you the answer to the problem. And as I mentioned before, no, of course. Sometimes studies are published in a very strong journal. The study is an RCT or even meta-analysis. You will find many flaws in these studies, and eventually you cannot use them. Whatever the evidence, you have to appraise it. Limitations of EBM, although it's a very important thing, but many limitations. Limited applicability of evidence to an individual patient. The evidence that is most applicable to the patient is the one coming from a study on the patient himself or herself. Such studies are possible and are usually termed N-of-1 trial, which is including only one patient, and no one will do a study on every single patient, of course. Therefore, the current evidence comes from averaging over a number of patients. And this is why we will see, although we have many, a common example, pharmacokinetics of medication. You will find many studies published on one of the drugs that you are familiar with for many years. And you will find that your patient, after applying the population pharmacokinetics coming from those literature, that your patient having a different outcome, which is usually the drug level, for example. The patient will have subtherapeutic or supratherapeutic levels. Although you are using the same doses recommended, the literature, you are considering the pharmacokinetics mentioned the literature, but you have your patient having specific criteria. For example, your patient having, let's say if the drug is affected by fluid status, having his own fluid status. A second thing, maybe some patients, they clear the drug more than others. We have always to remember that the studies were not done on the whole people in the world, only done on a sample that can represent the population. And maybe your patient differ from those samples, so you need to individualize the therapy. Lack of consistent and coherent evidence, such is in the case with many pediatric-related problems, especially those attributed with rare disease. Sometimes you are relying on evidence which is case report in order to manage your patient. Potential to limit, and this time when you are using a very weak evidence, always you have to remember the risk versus benefit. Potential to limit creativity and innovation, for example, by limiting research in a field that is not considered a hot topic. You all know that during the COVID-19, especially at the beginning, most of the studies were related to COVID-19. So only people were publishing and focusing their attention on this hot topic, and we missed opportunities on evidence-based medicine in other specialties. Need for time from clinicians to learn the language of EBM and apply it? Yes, of course. As I mentioned, it's a life learning process. So you have to go with it in order to manage your patients properly. Limited availability of EBM resources, and this is what we are facing. Sometimes you don't have an access to a specific article. This is why where organizations need to help. Like in KSU library, you will have some support. You can access some articles through this. Sometimes the departments can register in some journals and share it with the team. And sometimes in developing countries, the problem is the internet itself. Need to learn new concepts such as methodological and statistical ones that are sometimes hard to digest. Yes, this is true, but at least have the basics in the statistics. It will help you in appraising most of the articles. When you have something that is difficult for you, you can ask the experts in statistics to help you with. Confusing terminology, and this is the same like odds ratio, absolute risk reduction, risk ratio, or relative risk, and to differentiate between those. This is why I'm suggesting whenever we have a journal club among our activities, we can revisit those statistical terms or statistical parameters. We can every time and then remind ourselves what's the difference between absolute risk reduction and relative risk, and etc. Wrong assumptions, such as the assumption that risk ratio of treatments are more or less consistent across the patient subgroup and apply even to individuals. And this is, of course, one of the limitations. By this, I end my presentation. I hope it provided you with at least refreshment and reminded us all about the importance and the limitation of evidence-based medicine. Thank you so much. I'm ready for any comments and questions.